Welcome back to the Deep Dive. Today we are stripping everything back and focusing purely on high-yield revision.
hmm
If you're a resident getting ready for your board exams, especially the FRCS, this is for you. We're breaking down the clinical management of Velopharyngeal Insufficiency, or VPI, in cleft speech.
Yeah, this is one of those cornerstone topics. It's right at that intersection of, complex anatomy, really subjective assessment, and some pretty high-stakes surgical decisions.
It's a favorite for examiners.
Oh, absolutely. There are so many places for a candidate to slip up.
Which is exactly why our mission today is to just clarify the anatomy, the assessment, and the surgical algorithms.
Right.
We're going to run this like a question and explanation interview to really simulate that Viva environment.
Sounds good. And before we jump in, just a quick bit of housekeeping.
Go for it.
If this revision style is helping you out, please just take 5 seconds to rate the show. It really helps us reach more residents.
And we want to know what to cover next, so definitely drop a comment with your requests for future topics.
And most importantly,
If you want to pass, you should really get a premium subscription. It's the only way to access our journal club and the clinical cases episodes.
and those clinical cases really take the theory we're about to discuss and apply it to real-world scenarios, which is, that's the exam, isn't it?
Exactly what you'll face. Okay, let's get to work.
Let's do it.
So starting with the basics, but framing it for the clinic, we know VPI is a failure of the velopharyngeal port to close. But for an exam, how should we conceptualize that mechanism?
You need to think of the soft palate as a valve. That's its job in this context. It controls air entry into the nasopharynx.
Right.
And the velopharyngeal port is just that space between the soft palate and the posterior pharyngeal wall. In a normal state, you have complete control over that space. VPI is simply the inability to close that valve completely.
Okay, simple mechanics. But examiners won't just ask about mechanics, they'll ask about speech. So how does that valve failure translate into what we actually hear? Because it doesn't affect all sounds, does it?
No, and that is the key distinction. You have to separate your nasal consonants from your pressure sounds.
Okay.
So think about the sounds M, N, and NG. To make those sounds, you actually need air to pass from the oropharynx to the nasopharynx. The port's meant to be open.
So a kid with VPI might say mama just fine.
Perfectly. Mama, Nana, no problem. So the nasal sounds are actually, representing a normal function in that specific context.
So the pathology really shows up when the port is supposed to be closed.
That's it. We're talking about plosives, your B and P sounds, or fricatives like F and S. To make a really crisp P sound, you have to seal that port, build up intraoral pressure.
And if the valve leaks,
Air just escapes into the nose, and that's where you get that classic hypernasal speech. If a candidate says a patient is hypernasal on all sounds, they've just shown they don't get the physiology.
that's a great point.
Mhm.
Okay, etiology. Obviously cleft palate is the big one, but what else needs to be on our differential?
Well, the most common is definitely a cleft of the secondary palate, but you have to look for the subtle ones. Submucous cleft palate is a classic trap.
Where the mucosa is intact, but the muscle's not.
Exactly. The muscle sling underneath is diastased. Then you've got neuromuscular abnormalities where, the parts are all there, but the drive isn't. And then there's idiopathic congenital VPI.
And there's also a big iatrogenic cause we need to flag, specifically around the adenoids.
Yes, a previous adenoidectomy. This is a huge don't get sued point. In a lot of kids, a big adenoid pad is actually helping with closure. It's filling that posterior gap.
So you take it out.
And you unmask a latent VPI. The child goes in for snoring and comes out with hypernasal speech. It's a disaster.
A total nightmare. Okay, so moving beyond the speech itself, what's the secondary impact? Why is this so developmentally urgent?
Delayed language development. It's simple. If a child can't make the sounds, they often just stop trying, or their acquisition stalls. But, and this is so crucial for the exam, you can't have tunnel vision.
Meaning you can't just assume the delay is from the cleft.
Exactly. There are often comorbidities. You have to exclude hearing difficulty, which is incredibly common in these kids because of eustachian tube dysfunction.
Right.
You've got to rule out global psychosocial delay, even a tongue restriction. It has to be an MDT approach. You do not want to be the surgeon who operates on a palate when the kid actually just can't hear.
Good point.
Yeah.
Okay, we get the mechanism. Let's move to the clinic. We got a 3-year-old patient. Why 3? Why not assess earlier?
It's really about compliance and development. You generally can't do a formal, reliable speech assessment until a child can produce all their speech sounds. The text benchmarks this at around 3 years old.
Any earlier is just guesswork.
Pretty much.
So the child's 3, they're in the clinic. The text lists 4 key hallmarks of cleft speech. Let's walk through these, because describing them accurately is a whole station in itself.
For sure. So the first one is abnormal articulation. And this is fascinating. It's usually compensatory. The child knows they can't get closure, so they try to create friction or stop somewhere else. They might use the back of their tongue to lift the soft palate or even try to physically block the cleft.
And what does that look like to us?
It looks like facial grimacing. You'll see them straining, scrunching their nose up. And you'll hear it too. You'll hear clicks or other sounds that just don't belong in the language.
Okay, then we have the resonance issues. We've touched on hypernasality. But what about hyponasality? That seems a bit counterintuitive.
It does, but hyponasality is the opposite. It's decreased nasal resonance. It's that bad head cold sound. Clinically, this is a massive red flag.
Why is that?
If you see a cleft patient who is hyponasal, it usually means something is blocking the airway. It could be big adenoids or, and this is on us, an overzealous pharyngoplasty. You've closed the port too tight.
So hypernasality is a leaky valve. Hyponasality is a blocked valve.
You caught.
Okay, and the fourth sign is nasal airflow errors. The text breaks this down into nasal emission and nasal turbulence. This feels like a detail an examiner would love. What's the difference?
It is subtle, but you can hear it. Nasal emission is that audible escape of air on the pressure consonants, the P, F, S sounds. It has a sort of frictional quality, like a hiss.
Yes.
Nasal turbulence is different. It's got more of a snorting quality. It sounds more chaotic, more posterior. Being able to tell that hiss from that snort shows you have a trained ear.
Okay, we've identified the signs. How do we document them? We can't just write speech bad in the notes. What are the validated protocols we need to cite?
2 acronyms to have in your pocket. First is GOS-SPAS.
The Great Ormond Street Speech Assessment.
Right. That's the standard protocol for cleft palate and VPI. The second one is CIPSA.
The Cleft Audit Protocol for Speech Augmented.
Exactly. You'll see that one in multi-center audit study. If you're talking about research or audit in your exam, you drop CIPSA into the conversation.
Good tip. All right, we've done the bedside assessment, but we can't operate based on sound alone. We need to see the anatomy. What are the gold standard investigations?
Video fluoroscopy and nasendoscopy. And the rule of thumb is you usually need both.
Let's unpack video fluoroscopy first. That's the lateral X-ray view. What are we actually looking for?
It's a dynamic study. You're watching the whole speech mechanism in real-time profile, and you have a checklist. First, look at the palate itself. Is it long enough? Is it thick enough?
Right.
Then you look at the posterior pharyngeal wall. Is it moving forward to meet the palate?
This brings us to passivance ridge. I remember this being a bit of a contentious point.
It is. Passivance ridge is this bulge on the posterior wall that shows up during speech. The controversy is about which muscle causes it. Some say it's the superior pharyngeal constrictor. Others argue it's a band of the palatopharyngeus.
So for the exam,
just acknowledge the controversy. It's better than picking a side and being wrong. Just know it's there, and it helps with closure.
okay, what else is on the fluoro checklist?
You're looking for the genu, the knee of the soft palate. The position of that bend tells you where the levator muscle is pulling. If the genu is in the wrong place, your sling is probably anteriorized.
And the tongue.
Yeah, check the tongue. Tongue humping or any abnormal movement can actually obstruct your view or even the closure itself.
So fluoroscopy gives us that side profile. Why do we also need nasendoscopy? Why put a camera down their nose if we've got the X-ray?
Because the X-ray is two-dimensional. It completely misses the width.
Oh.
Nasendoscopy gives you that bird's eye view of the velopharyngeal orifice. You can see the relationship of the soft palate to the lateral pharyngeal walls.
And that tells you the closure pattern?
Exactly. Is it circular, coronal, sagittal? You can also spot these tiny defects or scars that are totally invisible on the lateral X-ray. This is the money shot for surgical planning because it tells you exactly where the gap is.
Perfect transition to management. So we've diagnosed VPI. Can we just fix this with speech therapy?
In cleft-related VPI, the answer is generally no. The text is very firm on this. You're dealing with a structural problem. Abnormal muscle insertions, a short palate.
You can't train that away.
You can't train a palate to be longer. You can't train a muscle to reinsert itself.
So conservative management is pretty much out.
For the most part. I mean, there are prosthetics like speech bulbs, but they're cumbersome. The text quotes Orticochea here, and it's a really powerful line. He said, VPI is like cancer. There is nothing to be gained by waiting to see what will happen.
Meaning once you confirm it, you operate.
Yes. If you delay, you just cement all those bad articulation habits we talked about.
Okay, Let's get into the operating theater. This is the really high-yield section. What's the algorithm? How do we choose the procedure?
It's a logical ladder. Step 1 is looking at the muscle sling. If the muscles are just in the wrong spot, like in an unrepaired submucous cleft, you do a re-repair, maybe in triple veloplasty, to posteriorize that sling.
And what if the muscles are okay, but the palate's just a bit short?
Then you're looking at palatal lengthening. The classic procedure there is a furlough double opposing Z-plasty. You're basically borrowing tissue from the width to add length.
But what if the gap is just too big? Or the palate is immobile? Or just way too short for a furlough?
Then you're in pharyngoplasty territory. This is where you're borrowing tissue from the pharynx itself to bridge the gap.
Okay, let's slow down here. This is where people get confused. Let's start with the posterior wall pharyngoplasties, specifically the superiorly based pharyngeal flap.
Right, this is a workhorse. You raise a flap of tissue from the posterior pharyngeal wall, but you leave it attached at the top, superiorly. Then you suture the free end into the soft palate.
So visualize that for us. If you put a flap right down the middle, where does the air go?
The air goes around the sides. You're deliberately creating two lateral ports. The central flap blocks the middle, and the patient breathes and speaks through those side channels.
And why is a superiorly based flap preferred over an inferiorly based one?
It's all about mechanics and nerves. First, when a superior flap contracts or scars, it pulls upwards, which helps lift the palate. That's what we want.
An inferior flap would pull down.
Right, it would tether the palate open. And second, the nerve supply enters from above. A superior base preserves that innervation, so the flap stays dynamic.
Okay, so superior flap equals 2 lateral ports.
I got it.
Now, let's tackle the lateral wall pharyngoplasties. This is the Hines versus Orticochia showdown.
The classic exam trap. You absolutely have to know which muscle is used in which procedure.
Let's start with the Hines pharyngoplasty.
Okay, in a Hines, you're raising two superiorly based flaps from the lateral pharyngeal wall. And the muscle you're lifting is the salpingopharyngeus.
Hines is salpingopharyngeus.
Okay.
And what do you do with them?
You rotate them medially and suture them high up on the posterior wall. The original idea was to create a dynamic ridge, but Hines himself admitted they often just scar down into a static bulk. It essentially just thickens the back wall to narrow the gap.
Okay, so now contrast that with the Orticochia sphincter pharyngoplasty.
The Orticochea is totally different. Here, you're raising your flaps from the posterior tonsillar pillars. So the muscle you're carrying is the palatopharyngeus.
Orticochea is palatopharyngeus. That's the key distinction.
That's the one to memorize. And the goal here is to create a dynamic sphincter. You transpose these flaps medially and you interdigitate them. You literally weave them into a small, inferiorly based flap from the posterior wall.
And what does that do to the ports? It sounds complicated.
It is. Visually, it creates one central port and two small lateral ports. But because you've cut the tonsillar pillars, the lateral walls can't pull away anymore. The sphincter tightens around that central opening.
Okay, and then there's a modification, Jackson's modification. How does that change the Orticochea?
Jackson wanted to simplify it. So instead of weaving the flaps, he just makes a transverse incision, a horizontal cut across the posterior wall. He takes those same tonsillar pillar flaps, the palatopharyngeus, and just insets them into that incision, suturing the tips end to end.
So what's the result, geometrically?
A single, narrowed central port. No lateral ports. And that is the key difference to remember. Orticochea is a complex mix. Jackson gives you one central hole.
That is fantastic clarity. So superior flap, lateral ports, Jackson central port. That helps a ton. Now, we are deliberately narrowing the airway here. What are the big complications?
Well, the immediate fear is bleeding. You're leaving raw surfaces on the posterior pharynx. But the big functional risk is airway obstruction.
Of course.
If you narrow it too much, you can induce obstructive sleep apnea. You've fixed their speech, but now the child can't breathe at night. Snoring is also very common.
And what about the speech outcome? Can you overcorrect?
Yes, you can cause persistent hyponasality, that blocked nose sound we talked about earlier.
Right.
But, and this is critical for counseling parents, temporary hyponasality is expected. For the first 2 or 3 months post-op, they're swelling, the flaps are stiff, it's going to sound blocked. You have to tell them this is normal or they will panic. It's only a complication if it lasts beyond that.
Great point. Okay, so to summarize the journey we've taken here, we started with the anatomy of the valve, moved to the assessment at age 3, looking for compensation and resonance, visualized the gap with fluoroscopy and endoscopy, and finally we selected a flap superior based for lateral ports or a sphincter for a central gap.
It's a logical progression. Anatomy dictates assessment. Assessment dictates imaging. and imaging dictates surgery. If you can follow that line in the exam, you'll be safe.
And I want to leave everyone with a thought on that trade-off we just mentioned. You're essentially trading a speech deficit for an airway risk. The goal is perfect speech, but the cost could be sleep apnea.
It's the central dilemma of VPI surgery. How tight is too tight?
That balance is what makes this specialty so demanding. We'll wrap it up there. If you found this useful for your revision, please rate the show. It really helps us keep these deep dives coming.
And seriously, go get that premium subscription. The next episode is Clinical Cases in VPI. We take these flaps Hines, Orticochea, superior base, and we apply them to actual patient videos and case notes. It is the best way to cement what you just heard.
Thanks for listening. Good luck with the prep.